no one feels blood pressure. You stub your toe, you immediately know about it. You have a heart attack, your body is screaming. But high blood pressure, it's quiet. It asks nothing of you. There's no pain, no fatigue, no warning. Here's what I want people to understand. Blood pressure is one of the most personal numbers you have. It's a window into what's happening into the blood vessels, your heart, your kidneys, your brain. A blood pressure over 122 over 82. It's not dangerous today. It's not even dangerous the next year. But if that's your blood pressure for the next 15 years, your arteries are aging faster than by the time you cross the threshold and you get into the 130s and 140s, and that's when people start paying attention to it, you have already done a decade worth of damage. The best time to intervene is before the damage accumulates and not after.
Welcome back to Infinite Health. On this show, we focus on the factors that quietly shape long-term outcomes, even when they don't feel urgent or dramatic. Blood pressure is measured almost everywhere in medicine, and most people know their number, but very few understand what it actually means for their future health. Arasi, today we're reframing blood pressure, not as a box to check at an appointment, but as one of the most powerful and modifiable levers we have for long-term cardiovascular health. I think everyone knows about blood pressure, but a lot of people might not understand it or really understand the importance. So it's nice to see you again. How are you doing today?
I'm doing great. I've had quite the week, but life's going on. It's good. Busy cath labs, lots of high blood pressure issues. But so it's a
Beautiful conversation. So, in your opinion, why do you think blood pressure feels so uninteresting or maybe even a low priority to most patients?
I truly think because no one feels blood pressure. You stub your toe, you immediately know about it. You have a heart attack, your body is screaming. But high blood pressure, it's quiet. It asks nothing of you. There's no pain, no fatigue, no warning. And our brains are wired to respond to things that demand our attention. Blood pressure doesn't do that. And I also think there's a cultural piece to it. It has been medicalized to the point where patients hand it over to their doctors and wait to be told what to do. Does it feel personal? And here's what I want people understand. Blood pressure is one of the most personal numbers you have. It's a window into what's happening into the blood vessels, your heart, your kidneys, your brain, and it's happening in real time. And we should own it more than any other parameter we can measure in our lives.
And how do you think it became something people only really worry about once it crosses a certain threshold?
That threshold, and that threshold has been a moving target. At one point, it was 140 over 90, and now it is 130 over 90. It became a clinical shorthand, and shortcuts are useful in medicine, but we can't treat everyone with the same intensity. And shortcuts can become dangerous when they turn into like permission slips. Oh, my doctor said my blood pressure is borderline. I'm fine. And that's the mindset I honestly fight every practice. The research is pretty clear that cardiovascular risk is a continuous relationship with blood pressure. It doesn't suddenly switch on at 130. The prospective study collaboration, a huge meta-analysis over a million patients, showed that risk doubles with every 20-meter rise in systolic blood pressure, starting as low as 115 millimeters of mercury. So that's not a threshold, it's a gradient.
And speaking about that threshold, what does that threshold-based mindset miss?
It misses time, and time is everything in cardiovascular medicine. A blood pressure over 122 over 82 It's not dangerous today. It's not even dangerous the next year. But if that's your blood pressure for the next 15 years, your arteries are aging faster than it should. Your heart is working harder than your heart is working harder than it needs to. And by the time you cross the threshold and you get into the 130s and 140s, and that's when people start paying attention to it, you have already done a decade worth of damage, which has been completely. And I also, this is opportunity window. The best time to intervene is before the damage accumulates and not after.
And why does mildly elevated blood pressure matter so much when you look at decades instead of months?
Okay, let's think about a water running through a pipe. A little extra pressure today, no big deal. The pipe holds. But
Mhm.
that extra pressure every day for the next 20 years, the pipe changes. The walls thicken, the lining gets rougher, small cracks happen, and LDL goes and sticks to it, plaque starts to form, and that's what happens inside. There is a concept called cumulative blood pressure burden. It's not just your reading today, it's the area under the curve over your life. So studies following patients for 20, 25 years, etc., like the Cardia study, have shown that cumulative exposure to even mildly elevated blood pressure in your 30s and 40s predicts a heart attack or stroke in your 50s or 60s far better than any single snapshot reading. So you can't see that in one clinic visit, but your arteries remember it every single day.
Absolutely. And how does cumulative exposure quietly change cardiovascular risk?
Multiple mechanisms. Let's focus on the three main ones. And I really want people to understand because they're not very abstract. They are truly, concrete things that happens in your body because of cumulative exposure. First, the endothelial dysfunction. What is the endothelium? It's the innermost cellular lining of your blood vessel. And it's a living organ. It's not wallpaper. Chronic pressure and or stress makes that inflamed and it makes it sticky. That's where atherosclerosis begins. Now, left ventricular hypertrophy. Left ventricle is the left lower chamber of your heart. Okay, and that heart muscle works very, very hard for you. And if even with chronic cumulative blood pressure changes, the muscle starts to thicken like any other muscle. Think of I am doing bicep curls and I'm progressively increasing the weight at which I do my bicep curls. The bicep begins to get thickened. So that's fantastic for my biceps,
Mhm.
not so much for my left ventricle. The more thick it gets, the stiffer it gets. So think of a body weight champion, right? He's got good, thick, defined muscles, but he's not going to be able to stretch and do ballet. So he's a stiff but muscular person. And that's what happens to your heart. It becomes thick and it cannot relax. The left ventricle has two functions. One is to contract and empty out and send blood to the rest of your body. The next is to relax and receive pure blood from the lungs. So when it can't relax and it's like in a state of chronic, thickened or stressful state, it just feeling like this, it's not relaxing, receiving blood and squeezing. So you want it to be nice and pliable, receive the pure blood from the lungs, then squeeze it out. It just cannot do that. And the same thing happens to the blood vessels also. Your carotids, which are supposed to be nice and elastic like a bendy straw, because they are buffering with each heartbeat, they stiffen. But they do that automatically because you're aging. But when your blood pressure increases, it just becomes harder and harder. And your kidneys and your brain, they need steady flow. And it starts taking a hit. And all of these three things happen without a single symptom. That's why it's called the silent killer.
Absolutely. And why is waiting for symptoms the wrong strategy in preventative care?
Because symptoms in cardiovascular disease often means the event has already happened. The heart attack, the stroke symptoms, the chest pain, breathlessness on exertion, these aren't early signs, they are consequences. So I tell my patient, if you wait until your car makes a noise to check the oil, you've already damaged the engine. The whole architecture of modern preventive cardiology is built on catching risk before the event, but not it does not mean managing the aftermath. And from a purely statistical standpoint, half of all the first heart attacks occurs in people with no prior cardiac history. Half. That's not an argument for anxiety. That's just an argument for data. Know your numbers. Don't wait for a symptom to tell you something like your blood pressure cuff already knows.
Mhm. And how do you personally think about normal versus optimal blood pressure?
Okay. Normal is a statistical concept. It means you're within the range of most people your age. Optimal is a biological concept. It means your heart and vessels are under the least possible strain, and those are not the same thing. In populations where hypertension is essentially like isolated rural communities, like places in Africa or the Amazon, average pressure runs around 110/70 throughout their lives. It does not rise with age. It does not rise with age like the way ours do. That tells us our normal rise in blood pressure with aging is not inevitable. It's environmental, it's lifestyle, and therefore modified. I target under 120 systolic for most of my patients. And I use the sprint trial as my anchor. It showed a 25% reduction in cardiovascular events and 27% reduction in all cause mortality with intensive control under 120 compared to the 140 target. That's not a marginal benefit, that's significant. Having said that, you can't have a 80-year-old or a 70-year-old balance issue at 110 because they have balance issues and small variation in pressure can lead to falls, etc. So it's a truly clinical decision, and I go for optimal versus normal.
And we talked a little about lifestyle, but when is lifestyle truly enough? And when does medication actually become the right decision?
Whew. Lifestyle is always the foundation. I
Mhm.
never walk away from that, like exercise, salt control, sleep, stress management, diet. These are not soft suggestions. They are biologically active interventions with measurable hemodynamic effects. Regular aerobic exercise alone can lower blood pressure by 5 to 8 millimeters of mercury. That's comparable to a low dose medication, but lifestyle has a ceiling, and that ceiling is partly genetic. If someone has a strong family history and they've already had end organ damage, even subtle things I see in an echocardiogram or kidney function, then I'm not willing to wait because because waiting has a cost,
Mhm.
and that could be progressive kidney disease, atherosclerotic buildup, etc. And at the same time, taking a medication, it's not a failure. It's not a moral, misconduct or something like that. I have patients who tell me they don't want to be in medications and they don't want to give to medications. And if I start a medication, I'm never going to be able to stop, etc. Medication is a tool that buys your organs time, and science can help you. Why not use it strategically?
Mhm. And I think that you've probably seen patients try to manage blood pressure on their own. So, what mistakes do you see when patients actually do try to manage blood pressure on their own?
Um, several mistakes, but let's just focus on a few here. One is relying on a single number. Blood pressure is a spectrum, it's a dynamic number, fluctuates with stress, caffeine, sleep, posture, even the temperature in the room. So, one reading in your doctor's office, especially a stressful one after you had to overcome traffic and you couldn't find parking, etc., tells you very little. I want home readings and I want a 7-day average because I want to see the pattern. Okay. Number two, confusing a good reading with a solved problem. Patient starts exercising, drop their blood pressure, they feel great, and they stop everything. Okay. Lifestyle changes work only while you are doing them. Blood pressure management is not a sprint, and it's what I've named one of my podcasts, the previous one, Reboot. You are constantly rebooting yourself. And now I call this podcast Infinite Health because it's ongoing. And finally, the third thing which I would tell you is taking advice from people who are not accountable for the outcomes. This is something I feel strongly about. An influencer can recommend magnesium supplementation and, take magnesium and your blood pressure goes down. Take red beet powder and your blood pressure will come down. But you know what? I'm the one standing in the cath lab at 2 a.m. doing fixing a heart attack or, putting in a balloon pump because things didn't go well and your heart is in complete failure, etc. And that's an intervention. It's too late. That's the difference in accountability, and it should matter to everyone. And honestly, that's the whole point of this podcast.
Absolutely. And being that you see so many people try to, like you said, manage blood pressure on their own, and you work with so many different people, if someone could change just one thing about how they think about blood pressure, what should or would it be?
Stop thinking the diagnosis of hypertension or high blood pressure as a verdict, right? And start thinking of it as when your blood pressure is high, your body is not broken. It's just telling you something. It's just telling you your system is under load and the load is manageable. You can reduce it, you can track it, you can act on it. But first, you have to be curious about it. The
Mhm.
people who best in practice are not the ones who are afraid of their numbers. They are the ones who do well, are the ones who are most engaged with them. They know their trends, they ask questions, they bring their home readings, and that's the kind of ownership that's genuinely protective.
And how does blood pressure fit into a broader long term longevity strategy?
Oh God, I hate the word longevity, and I think we've talked about that.
Mhm.
It's prevention.
Mhm.
Uh, Longevity is not about living to 100 because no one wants to be living to 100 in diapers with absolute no control, no agency over their
Mhm.
life. It's about living well to 100. And blood pressure is truly central to it because it's upstream of almost everything: cognitive decline, heart failure, kidney disease, vision loss. The common thread in all of them is vascular health, and blood pressure is the single most modifiable vascular risk factor we have.
Absolutely. And why is this one of the highest leverage interventions that we have in medicine?
Because this number is measurable, actionable, reversible. That combination is truly rare in medicine. We can't easily measure inflammation in real time. We can't watch a plaque form in real time, but we can measure blood pressure anywhere, anytime with a device that costs $30 or less. And then we can act on it through lifestyle changes, medication, interventions. We now do renal artery denervation, which is a beautiful procedure, and its studies are encouraging about the reduction in numbers. And when the number moves, outcome changes. The global burden of disease study identified high blood pressure as a single leading risk factor of death worldwide, more than smoking, more than obesity, more than physical inactivity. And yet, It remains dramatically undertreated. That's not scientific failure, that's a communication failure. And that's exactly, Leila, why we both are here talking about high blood pressure.
And speaking about that too, wearables are something that I think has become more common. So, wearables, continuous blood pressure monitoring, are we there yet? And does it change anything clinically?
Well, we are getting there faster than most people realize. Traditional blood pressure cuff, as I said before, is a snapshot. You sit still, someone wraps a cuff around your arm, you get a number that reflects maybe a 30 seconds of your cardiovascular life. That's a deeply imperfect way to understand a dynamic system. What we actually want is, what is your blood pressure while you're sleeping? During a very stressful meeting, after you exercise. Cufflex, cuffless technology is using photoplethysmography, pulse transit time, optical sensors are being built into devices like the Samsung Galaxy Watch or under active development with Apple itself. The validation data is still catching up to the hardware, but the trajectory is clear. And why does this matter clinically? Because nocturnal hypertension, that is elevated blood pressure while you are sleeping, is one of the strongest predictors of cardiovascular events, and it is almost completely invisible to standard office measurement. If we monitor that continuously, passively, we can fundamentally change how we risk stratify patients. That's not a gadget update, that's a diagnostic revolution. I can't wait for it.
And yeah, there is so much that's developing with tech. And speaking about AI a little bit, how do you think that AI is actually beginning to change the way that we detect and manage high blood pressure? And what should our audience really know about it?
AI in hypertension is moving in two directions simultaneously, and both are important. The first is detection. There are now algorithms trained on ECG and retinal photographs. They can identify elevated blood they can identify elevated blood pressure with remarkable accuracy, even without a cuff. A study out of Mayo Clinic showed that an AI applied to a standard 12 lead ECG can detect patients with low ejection fraction that no one has ever diagnosed. We are seeing similar work in high blood pressure. Your eye doctor's fundus exam may soon double as a cardiovascular risk reader. That's number one. The second is personalized management. Traditional medicine gives everyone the same risk category, the same protocol. AI fed with continuous wearable data, genomics, lifestyle inputs, etc. It can model how your blood pressure responds to your specific triggers. That's precision medicine in the actual sense of the word and not just a marketing phase. What should patients know? That AI is only as good as the data you feed in. If you're not measuring, you're invisible to the model. Engagement is not an optional thing, it's actually an input.
And as someone at the intersection of cardiology and healthcare innovation, what do you think is one tech driven shift in hypertension care that you're most excited about?
I mentioned it briefly earlier, renal artery denervation. It's a procedure performed in the cardiac cath lab for resistant hypertension. It works by disrupting the overactive sympathetic nerve signals between the kidney and the brain, drives the blood pressure up. The final trials have shown durable reduction up to 8 to 10 millimeters of mercury reduction in blood pressure over 3 years in the right patient. But the right patient piece, as always, challenge. We don't always know prospectively who will respond. What I'm watching closely is whether continuous digital biomarker, heart rate variability, circadian blood pressure patterns, sleep quality scores, can these help us predict responders before the procedure? And if we can use wearable data to identify the patients whose hypertension is most sympathetically mediated, that is, mediated through overactive sympathetic nervous system, we can offer precision intervention to a precision selected population. That's the future we are all working towards, not just treating the disease, predicting who needs what before the damage is done.
Absolutely. I think that all these innovations are going to be so helpful for patients and for providers moving forward. And blood pressure rarely feels urgent, but its effects are anything but small. So, understanding it through a long term lens isn't about fear or perfection. It's about recognizing how small, consistent decisions quietly shape future health. And this is the essence of preventative medicine, really paying attention early, acting thoughtfully, and letting time work in your favor rather than against you. So, thank you so much. I think this is another great conversation that we're having. And for everyone listening, make sure you follow the show, subscribe, and share. And thank you again so much, Dr. Moran. Is there anything else you want to say?
Well, Leila, I think this was a fantastic conversation. And I hope at the end of this episode, people are not afraid of their blood pressure. Instead, they just own it and, fight for their health like they should.
Absolutely. Thank you for being so encouraging and shedding all this light on such important conversations. So I can't wait to see you next time. And remember, everyone listening, make sure you do follow and share the show. And I can't wait to talk to you soon.
See ya.